Hi, I'm Catherine Bertram of Johns Hopkins Center for Communication Programs and Senior Social Behavior Change Advisor of the READY Initiative. I'm here with Doug Storey. Doug is the Director of Communication Science and Research at Johns Hopkins Center for Communication Programs and Associate Professor with the Johns Hopkins School of Public Health. In this session, we're going to learn from Doug a little bit about what makes a good rapid assessment survey to understand perceptions, beliefs, and norms around behaviors to mitigate COVID-19. What are some of the common mistakes people make in survey design, and how can we get it right? How can we use this data to build better programs? I hope you enjoy this session.
Well, the most challenging thing, I think, at this point, when it's difficult to, and when there are a lot of restrictions on face-to-face interaction, it's really difficult to recruit some of the most vulnerable and hard to reach populations. Um, a lot of the limitations on face-to-face research right now have pushed us toward the use of digital technologies, phone interviews, online interviews, Zoom focus groups, things of that sort. And for people who are sort of at the margins of society, their access to those digital technologies for the sake of recruitment and data collection are much more limited. So we face especially challenges in trying to recruit people from those population groups. And here I'm talking about the urban and rural poor, about women who may not have access to a cell phone in their household, and groups like that. So we're having to be much more creative in the way that we recruit and interview people who fall into this more vulnerable category. And I can just offer one example. I don't think there is a one-size-fits-all. This is something that researchers and programmers will need to sort of discover or create in their own particular context. But I can offer one example from Indonesia. Recently, the government of Indonesia asked us to conduct some what they called community check-in interviews. And they had typically used phone surveys, cell phone interviews and or online monitoring. But many of the people in this category now are affected by the economic downturn and the isolation. Many are unemployed and have sold their cell phones or discontinued their internet service in order to provide for their family. So they could no longer reach these people. So the creative solution that we came up with was to work with some local NGOs that were distributing emergency supplemental food aid. And so we arranged with them, the volunteers who already practiced, hygiene and safe distancing procedures, sterilizing or washing and sanitizing their hands and sanitizing the food packages that they delivered and so on. We engaged them to recruit some of the families from these low-income households who were receiving food aid. The volunteers who were doing the food deliveries had cell phones. So we asked them to, first of all, recruit households, and then on the day of the interview, they would go to the house, wipe down their cell phone with a sanitizing wipe, dial the number of the interviewer who was sitting back in our research office in Jakarta, hand the cell phone to the head of household, and the interviewer in Jakarta would conduct the interview. Then the volunteer would take that phone back, sterilize it, and thank the respondent. So in that way, we were able to create a panel of respondents that are providing this check-in on a 2 to 3 week basis. So it's that kind of thing that you have to worry about, particularly reaching the vulnerable, more isolated population subgroups now, so that the sample of people that you are collecting information from really represent the population at need, the population that you're intending to serve. A common mistake is to overestimate the representativeness of the population that you can reach using those digital technologies. We know that not everyone who has access to a cell phone also has access to wireless and is able to access online information. So even those who have access to various digital technologies are not necessarily representative of a larger population. So, and so you need to be very careful to profile in the first place who you are able to reach through, let's say, a text-based survey, an SMS survey. Who has access to that? Who would be missing from a sample that you drew from that population? And having done that, you're in a better position to come up with these creative solutions like the one I described in Indonesia. So I think some people may be familiar with the social ecological model, and we may refer to that a little later in this conversation as well. But the social ecological model says that people are individuals are embedded. They live in households and families, and those households and families live in communities, and the communities live in some kind of a society with a health infrastructure and services that are available. And at the highest level, people live in societies that have policies and laws and regulations and rules and resources and so on. So all of those things, at each of those levels, there may be things that influence first what choice a person makes to act in one way or another, but also whether they're able to act. But typically we think about sort of two general buckets of predictors or determinants, if you will. One are these more individual level variables or factors that we often describe as being psychosocial or psychological or sociological in nature. The other bucket, the other big category, is what we might think of as structural issues, structural factors. And these are things like access to services or access to resources or policies that are in place that determine what a person is allowed to do or can do should they choose to. Yeah. So you have on the one hand the more individual level variables, and on the other hand you have the more structural variables. In behavior change communication, social and behavior change communication, we focus quite a lot on the psychosocial determinants. And some of you who may be familiar with the work of CCP know that we often use what we call the ideation model. The ideation model describes about a dozen of these psychosocial variables that range from knowledge about the disease threat. In the current context, it might be what you know about COVID-19 and how it spreads and what can be done to prevent it. So there's a knowledge component. There are attitudes about the behavior. In the case of COVID-19, one of the behaviors that is often encouraged is to keep your distance from other people. So what are your attitudes about that? What do you think about that? Does it seem like something that's easy to do? Is it something that's compatible with your lifestyle, your daily life, or do you have to be close to people? Is keeping your distance from other people a good thing or a bad thing to do? So those are sort of the attitude aspects of ideation. And then you have things like social norms that describe what the people around you are doing, or what you think the people around you are doing, and what they expect of you. So when you go out in public, do your friends and neighbors expect you to be wearing a face covering? Do they expect you to be keeping your distance? Or do they see that as something that's strange or weird, or impinges on freedom, or something like that? So those are the normative factors. And then there are some factors that are related to how you perceive the disease or the threat, the health risk that you face. If you were to contract COVID-19, do you think that it would be serious? And secondly, do you feel that you're susceptible to it? How likely do you think you are to become infected with COVID-19? Those are some risk perceptions. And then finally, there's a category of variables or predictors that we call efficacy. And there are a couple different aspects of efficacy. Response efficacy refers to whether you believe that there are things that can be done that will make a difference. So do you believe that masking, wearing a face covering, would help prevent the spread of COVID-19, would help protect you, or would help protect other people? Do you believe that keeping your distance from other people when you go out in public will help to prevent the spread of disease? So do you believe in the solutions? Do you believe in the preventive behaviors that are being encouraged? And the second part of efficacy is what we refer to as self-efficacy, which is, do you believe that how confident are you that you can practice those behaviors? Mm-hmm. So when you go out, will you be able to keep your distance from people? Will you be able to wear a mask in public and still be able to function and do the things that you need to do and talk to the people you need to talk to? So that efficacy has two components. It's that set of what we call ideation variables that are most important to consider, I think, when trying to develop behavioral messaging. Now, there's one other category of predictor that, I mean, there are many others. I'm simplifying. There are things like stigma, if you think that you might be stigmatized if you become infected. But there's a larger category that we might think of as behavioral control. So can you access services? Can you buy a mask? Can you make a mask? Do you have access to COVID testing in your neighborhood? So even if you wanted to get tested, would you be able to? So it's the combination of those things. When all of those things are positive, behavior tends to be more likely. So it's usually a combination of things that we need to consider. And we would want to ask questions about those in a survey to determine which ones are most important to the population we're trying to address. Our theories, like ideation, suggest that there are certain questions we should be asking people about self-efficacy and response efficacy and risk perception and knowledge and access to resources and so on. And so you can design your study, design your rapid assessment study, ask them about the behavior itself. You know, do you wear a mask when you go out, or how likely are you to practice physical distancing when you leave your home? Mm-hmm. By asking those predictor questions and the behavior, then we're in a position to analyze the relationships between them and see which of those predictors are in fact related statistically to the behavior we want to encourage. So the first place we go wrong is by not using those theories as a guide to choose our questions. Mm. The second place where my students often go wrong is after they've collected the data, they don't quite know how to analyze it, don't know how to make sense of what the data are telling them, and that's the point of your last question. So again, I think the solution is to go back to those models, go back to those theories, and say the theory tells us, for example, that people who are really afraid of a disease like coronavirus,
Mm-hmm.
and and are therefore motivated to do something. They're afraid, they don't want to become infected, and they know what to do to help prevent that from happening.
Mm-hmm.
So they perceive that they are at risk, and they know that there are things they can do, like masking and physical distancing. And so you can then analyze your data, analyze the results of your interview, your survey, with that in mind, right? You can use the appropriate statistical tests to say, are people who perceive COVID-19 as a threat and who know that masking is an effective way to prevent it, are they more likely to use a mask? And so the theory, again, helps you to analyze the relationship between the predictors and the outcome. You know, it's usually a combination of psychosocial variables and structural variables. So it's not just a matter of someone knowing that COVID is a threat and knowing that wearing a mask is a good thing. If they can't get a mask or they don't have the materials to make one, what is your communication strategy in a case like that? It's not trying to convince people that masks are a good idea. It may be trying to convince the healthcare system to provide more masks. It might be trying to work with the private sector to respond to a market demand for more masks. So this is also something that you could try to build into your rapid assessment. We would want to ask people about where they receive their information about COVID-19, or where they prefer to receive their information. This goes back to one of our earlier points about how different audiences have access to different channels. So you would want to ask people how they receive their information, and then design your strategy to deliver information using those channels that people have available to them. I would suggest that the first thing to do would be to look at data that are already being collected. So for example, service delivery statistics. If we want to know how a program is improving, is progressing over time, often service delivery statistics can be a proxy for that. It can at least tell part of the story. And as social media become more widely used in our programs, we can consider using the back-end data from online platforms to capture some aspects of public response. Like you can often tell a lot about public opinion by looking at what people are posting or reading, or accessing or sharing on online platforms. You can track rumors through online back-end data. And so it's important to sort of, first of all, look at what kinds of information are already being collected. Some community groups or NGOs, civil society groups that are doing public health work at the community level, document their work on a pretty regular basis. They're required as a part of their program to document, to record, to keep records of what they do. And so that might be another source of information that's already being collected, or could be modified or refined a bit to include additional questions or additional information about what might be happening at the community level. So rather than try to create a new standalone monitoring system that would make community visits every month or every quarter, or do rapid assessment surveys or telephone surveys or SMS surveys, something like that, First of all, look at what data are already being collected and see whether there are things that can be learned from a longitudinal analysis of those data. You can collect them, compile them monthly or quarterly or annually, and report on those. They can often provide really important information. The humanitarian crisis, the disruptions of an outbreak or any other kind of a crisis, it just makes these things more complicated, but it doesn't really change the considerations. It just makes it a little more challenging to find creative solutions. Well, people may not like to hear this, but I think probably the main thing is to try to maintain realistic expectations for what these rapid assessments can provide. They can be very informative, but they will never give you a complete picture of how a COVID-19 program is going and what its impact will be. And these rapid perception surveys will never be a substitute for a comprehensive impact evaluation. It's just not possible. But rapid perception surveys can be part of the picture. They can be very powerful, very useful, but don't expect them to provide all of the answers. They really need to be complemented with other sources of data, other sources of information, in order to feel confident about what we know and how we understand the outbreak we're dealing with.